everyone. Thank you for coming. I have the pleasure of introducing today my friend, my whiskey partner, Dr. Victoria Lukasik. Dr. Lukasik graduated from Washington State. She went on to Cornell to do her residency, and she's been boarded in anesthesia for a few years. We're the same age, so we're very sensitive. She lectures both locally, nationally, and internationally. She spends some time speaking at the World Health Organization. She has also been asked for a lot of her time at NIH. So I feel very, very fortunate to have her here tonight, and I think that you're all in for a wonderful evening of CE. Dr. Lucas?
To turn the microphone on, I'm like, wow, that was a nice introduction, thank you. We just need a little bit less light in the front. Perfect. Thank you guys for coming tonight after a work day. I know what it's like to work during the day and then try to do something at night. So hopefully we can have a good exchange. There's only 2 rules. Number 1 is you have to learn 3 things tonight. And the other rule is if I ask a question, I really want to answer. So, I know some of you are still eating. So the people who have finished will be on the hot seat for a little while. And if no one answers, I'll call on people. So if you like your friends, or if your friends don't like you and they point to you, I'll call on that person. So tonight we're going to talk about managing anesthetic events, and I actually manage anesthetic patients. I don't sit in my office and have other people manage them. I actually am on the clinic floor doing the anesthesias myself, and I've done it for 20 years. So that puts me in the same place as you are when you're looking at a patient who's under anesthesia and goes, oh crap, what do I do now? Excuse the language, some of those words aren't bad where I came from. So there's a few others that I say that people are like, oh, I'm like, that was not a bad word where I came from. It's okay. So we're going to make some decisions today. And the decisions that we start out with are, right, this is our patient. We first decide, do they need a procedure or do they not need a procedure? And then we decide what drugs we want to use, what fluids we want to use, with the doses of those things, how quickly we're going to administer them, how we're going to keep them warm, the size breathing circuit bag. The technicians take care of a fair amount of those things for us, but someone had to teach them how to do it. So once we get past all of those things and they're finally asleep, why do we write stuff down? I go, because we need to make decisions based on that information. There's no reason to write anything down if we're not going to make a decision based on the information that we have. So one of the keys to reducing anesthetic events and minimizing the amount of times we have to intervene. We all know the best anesthesias are 1,000 small adjustments with no big ones. Anytime we really intervene, it's kind of a big adjustment. Some are way bigger adjustments than others, right? So if we have to give epinephrine to restart the heart, that's kind of a big adjustment. If we just have to turn the vaporizer down a little bit, well, that's a minor adjustment. But we'll find those things by actually looking at the physiologic values. And so when we are trying to minimize anesthetic events, it makes things smooth. And the whole goal is for the patient to wake up better than they were before we anesthetize them and perform the procedure on them. The goal is for them to not have memory deficits, to not have kidney dysfunction, to wake up and return to normal function as quickly as possible, because that really promotes healing. Well, we can do those things by monitoring anesthesia. We should have a dedicated, vigilant monitoring person, and that's been proven over and over again to reduce morbidity and mortality. The other thing that we do is to watch our patient with limited distractions. So it's not the time to come talk to people about their time card or how much dog food they took home last week and charge them for it. You know, it's like we need to really just talk about only anesthesia and look at anesthesia, but we also need adequate training. We only find what we look for, and we only recognize what we know. If we've never been taught what normal is, we're not going to know what it looks like. And especially comparing something that doesn't look quite right and saying, I recognize that as abnormal. Because what do we like to do when we see something weird on the ECG? We like to blame the machine, right? They go, oh, that ECG messes up all the time. That's like, well, if you don't know what those abnormal waveforms look like, it's very easy to say, well, I have no idea what's going on. I'm going to blame the machine, because it couldn't possibly be the patient. So you go, no, we have to train to find those things. And then the other thing that's really been proven to significantly, and there's significance in statistics, right? Because it's kind of when we went to school, they said, well, it's statistically significant. I go, who cares? Is it clinically relevant? Is it going to impact the way that I practice? So what if this group is 5% different than the other one, and there's a 95% chance it's real? You know, whatever. Now, is that going to make a difference in clinics? I don't know. But the thing that does make a difference in our vigilance, in our ability to recognize things quickly, and this has been shown to be clinically relevant and statistically significant, is data recorded every 5 minutes and data recorded in a graphical type of trend, because our brain will recognize it much more quickly. So when we record records, this one looks super neat, right? They go, that's neat and it's tidy and it's aesthetic, because we are all OCD, right? In this profession, we are all OCD. We want everything in neat little columns. We want to be able to find things quickly. We want to be able to write in little boxes and have it look good when we're done. The problem is that this messiness, our brain clicks to that right away. So you go, where are the events where the heart rate drops significantly over 10 minutes? The dots are the heart rate. Where'd it fall? You go, bam, right there. Our brain will see that. You go, oh, wait, where did that happen again? Right here. Boom, we see that. You go, wow, where did it happen here on this paper? If we write 112 and then we write 92 and then we write 84, we go, we're writing numbers. We have to start subtracting them, right? We go, well, how different is that? So once we have to put math into the whole assessment part of it, it's hard to see. We need no math here. There's no math. So this sheet has been shown to significantly reduce major and minor anesthetic interventions in a significant and exponential fashion. You go, ugh, who wants to do that? I do. So if you're using a sheet like this, that's better than nothing. That's been proven to be better than nothing. But if you're using a sheet that looks like this has been proven to be the best to do it. And what they found out with people is that it doesn't matter if the machine makes the graph for you and you don't write anything down, or you make the graph yourself, but it has to be in real time to find it. So that's my little thing. Monitor, 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 write something down. Writing numbers down is better than nothing, but if you can get your staff, or the staff says, we want to use a graphical record and we're going to volunteer to learn to use it, don't complain. Because when a staff gets a graphical record like that, say learn what the symbols are and start putting them in, what's the first thing they do? That's way too complicated. Go, no, but know that you're being asked to do that because it's going to be really an improvement in recognizing things sooner rather than later. Because when we get recognizing things later, it's bad. Can these lights go down just a tiny bit more? Is there anyone in this room who can do that? Cheryl, you're my hero. So we're going to talk about patients, because patients are important to us every single day. And this is Wheatley. And what I want you to see here is this little black tumor in Wheatley's eye. And I want you to see the look on his face. Does he look like a happy cat? No. Oh, that's good. Sorry, you guys are... yeah, it's a little too dark in the back. Wrong button. Right button. Whatever. We're good. At some point, you just throw your hands up and go, you know what? Whatever. So Wheatley's an 11-year-old Maine Coon, and he weighs a lot. Is he supposed to weigh that much? Go. 32.8 pounds. Well, he could weigh that much if he was a very big Maine Coon. The problem with Wheatley is, oh, and he has this RS mass, we already looked at it, but he also has diffuse restrictive airway disease. Does he breathe well? No. Is that a good thing or a bad thing? Bad, right? No. So there's no questions that are not going to be easy questions, okay? So it's a bad thing that he doesn't breathe well, because if you can't breathe, nothing else matters. Okay, he vomits every single car trip. Nice, right? So is there something we can do about that for the day he's coming into the clinic? So make a decision long before we're inducing him to make his day more comfortable. Which drug would we like for them to use at home? Cerenia, perfect. So you go, okay, here's your Cerenia. We'll give you some instructions on how to use it. I had them administer it orally the night before. Just I said, just however late you go to bed, just give this the night before. And so he actually, that was the first car trip he hadn't vomited in on his way to the clinic. It was perfect. And he is not a particularly cooperative cat. What does that mean about his sedation protocols? We need to use the higher end of the dose range, right? So go, all right, so we have to think about putting together a protocol that will sedate a not very cooperative cat that doesn't breathe very well. So these are his x-rays. So, yeah, that's a lot of insulation. And it also is squashing his lungs pretty bad. In addition to having airway disease, they're all squashed by his body fat. So here you go. Now, this is why this cat was referred to me, is because I'm crazy enough to make him asleep and then wake him up again. Well, we can all make him asleep. We just want to wake him up again. And you go, no, I don't want that responsibility. So that's when people call me, ring, ring, ring. Hey, Dr. Lukasik, we have this like 17 comorbid condition patient that's ready to die tomorrow. Do you want to anesthetize him today? Sure. So here you go. So we're going to go to the ocular surgery office. I'm going to drive there or whatever. And Wheatley's going to go there too. And the ocular surgeon is going to laser ablate this mass in the eye. That's fine. Do you guys see anything in his pre-anesthetic assessment that you don't like? Yep. So you go, we don't like any of that, right? And go, so we have to make some decisions. Number one, is he going to go to surgery or not go to surgery? The ophthalmologist says, not a problem. How long is it going to take? 12 minutes. So how long is it really going to take? That's right. So the surgeons are notorious at not being able to tell time. Notorious at it. So we go, his parameters look okay for baseline parameters. Is anything in his laboratory work surprising to us? Do cats drink enough water? They drink just enough to stay alive, and that's it. That's it. So, and even at that, what's their PCV? What's cat PCV usually? Yeah, right. You go, this is 57. Is that perhaps an indicator that he is mildly hypoxemic in a chronic fashion? So this could be polycythemia, like real polycythemia in this cat. So what do we want to check? We go, oh, maybe he's chronically hypoxemic. That's why his lungs sound lousy. He's overweight and his lungs are being squished. We saw that on the x-rays. And his PCV is a little bit high. We're suspicious that he could have chronic hypoxemia. What do we check? SpO2, exactly. You go, we're going to try to check SpO2. It's a no-go. Right? Right? Very uncooperative cat. So you go, ooh, I really wish we had that. Because that information would help us decide what? Not necessarily if he has to go on oxygen intra-op, but if he might have to go on oxygen post-op and then get that ready ahead of time. Because they're on oxygen intra-op, right? They're on 100% oxygen intra-op, so that's good. He's going to get so much oxygen at that time, his body's going to not know what to do with it. So, he got Cerenia, and I gave him a little more sub-Q because what happened with the ocular surgeon that day? So, give this the night before. Okay, we will. Ocular surgery says, we're going to start at 1. Okay, we're going to start at 1. What happened in that morning appointment time? It went crazy, that's right. So what time are we really starting surgery? It was actually more around, around 5. So it's time for more Cerenia. So, and then I gave him some terbutaline. What is terbutaline? It's a bronchodilator. Do you think that will help him breathe a little bit better? He has not been on it previously. So that's okay. So I mixed all the pre-medications in the same syringe and I gave them in 1 injection. Because how many injections am I going to get into this cat? 1, that's right. Am I going to get an IV placed before he's sedated? No. So the article that tells us that the semimembranosus muscles or semitendinosus muscles is the best place to give these IM injections was published in Anesthesia and Analgesia in December of 2013. And I'm sure you all read that journal. It's one of the most clinically applicable articles I've seen in that journal. What is it doing there? It should be in JAVMA or AHA where we all have a much broader audience to read something that's clinically applicable. The sedation scores were higher in that group, and the peak effects of the drugs were more predictable in that group compared to the lumbar group. They looked at other muscle groups too, but really what we're making a choice of is they looked at the cervical muscles. Do we want to give neck injections in small animals? I would say 0. They looked at the triceps. Hello, how many Chihuahuas are in our practices? Or Pomeranians, or Yorkies? Where's the triceps on a Yorkie? It's like, really? So our best choices are semimembranosus, semitendinosus, which is the caudal thigh muscles, or the lumbar. The lumbar was far inferior, far inferior. Why was it far inferior? They had anesthesiologists do dye injections in cadavers, and more than 50% of the dye injections that they gave in the lumbar area were in the fat or the fascial planes. So if we really, really want the highest chance of good sedation from our protocol, and we want it to happen in a very predictable 10 to 15 minute timeline, semimembranosus or semitendinosus is the place to give it. In this cat, I go, I don't want to fiddle with this. I want this to really, really work in 5 to 10 minutes, and I want to have the best sedation score that I can get with this. See, could not get baseline SpO2. It's the big 0. When is this cat going to start getting supplemental oxygen? Immediately, exactly, as soon as we can put the mask on. Now, is he going to like the little rubber diaphragm on his face? Never. So you go, we'll take the rubber diaphragm off. There's no patient who likes that. So you go, well, we'll just take the rubber diaphragm off. We'll just pre-oxygenate without it on the mask, and he'll be just fine. And so that's what we did. We go 5 minutes. Well, he was amenable to IV placement. He was amenable to being affixed with monitoring cables. And about that 5 minute timeline, he said, I've had enough. It's like, well, I'm going to induce you then. We don't have to sit here and try to fix the blood pressure that was working marginally and stuff. I go, no, I'm just going to induce you. Because how much induction drug am I going to need if he gets too angry? A lot more than I want to use, because I don't want him to go too deep. So that's another decision. Go, do we wait for the blood pressure cuff to work, or do we just induce now? We would really like to get that baseline pressure, but sometimes we can't. We just have to move forward because we're making a decision on the comfort of our patient and also what's going to come next. So we go 1 VPC during induction. Is that a surprise? He's got bad lungs, and he's heavy, and we've stressed him. Right? So you go, no, that's not a surprise. If they start coming back, then we have to talk. But just 1 is fine. So look, his total anesthesia time was 39 minutes. His recovery was smooth. His pharynx was very clean. I was a little concerned about the fact that he has goop in his airways. And so you go, no, the endotracheal tube was very clean, so there wasn't a bunch of mucus or goop in his endotracheal tube. So that's good. Post-oxygenated him for about 10 minutes while we're waiting for him to wake up and to be extubated. Go, that's fine. So then we discontinue his face mask of oxygen. What are we going to keep on looking at? We're transitioning him from 100% oxygen when he was asleep, right? To supplemental oxygen while he's waking up. Now he's going to go where? On room air, right? What does he have to continue to do when he transitions to room air? Well, breathe well, oxygenate his blood. He has to be able to oxygenate his blood well enough. And this is where, if we know that he only oxygenates in the high 80s on a regular basis, we go, oh, well, maybe 88 is good enough for you right now. But what are we striving for the numbers on our pulse ox? 100, but high 90s, right? High 90s. What are the chances this cat is going to be in the high 90s? 0, exactly. So maybe we're looking for 91 or 92. But if he was only 88 to start with, which they're still pink when they're 88 or 89, it's not until it gets much lower than that that they're visibly blue to us. So we go, well, let's check it. Oxygen mask comes off. This is what we see. Heart rate goes up to 196. SpO2 falls to 87. Are we going to wait to see how low it goes? No, so we made another decision. Oh, we don't like this. That's the decision we made. But what do we do next? Put the oxygen mask back on. Exactly. Now, how amenable is he to the mask by now? No, not so much. Go, but he still was kind of weak. You go, he still is seeming like he doesn't have quite as much muscle tone as we would like him to have. How much muscle tone do we need to breathe when we have airway disease and we have fat in our chest squashing our lungs. Pretty good muscle tone, right? So if he still is a little bit weak, we go, maybe it's the midazolam because that's a muscle relaxant. I go, so I reversed it with flumazenil. And I will generally use just an equal volume of flumazenil as I've given of midazolam, and that seems to work very well to reverse it. So the dose that's published in Plum is 0.01 mg per kg. They go, that's kind of the dose where if they took a whole bottle of Valium, we could reverse it. He didn't take a whole bottle of Valium trying to commit suicide. He got a little bit of midazolam in his anesthetic protocol. So go, we'll just choose an equal volume, and we'll try that. And so his muscle tone came back really well. So what's he doing now? Oh, yeah. I go, but his SpO2 is still falling into the 80s. So what do we have to do? Now, I'm at the ocular surgery practice. It's a standalone ocular surgery practice. Do they have an oxygen cage? Do they even know what an oxygen cage is? They do not. So I go, oh, I'm going to have to make one. So I took Antec bags and cut them up and used Scotch tape to put them together to make a clear drape to go over the door of the cage. So I could see him through it. And the brand was Antec. You could use Idex bags, or you could use Ziploc bags, or you could, the brand doesn't matter. But the point is that I had to make an oxygen cage. The anesthesia machine rolled over to there, and we just piped the oxygen in from the anesthesia machine. Do we know what % oxygen it is? No. But if we're adding oxygen to a closed space, you would think that the % oxygen will be increasing, right? Common sense says it should increase. So that's what we did. And here he is. Now, does he look happy? Well, his mouth is open a little bit, so he's a little bit open mouth breathing. And he looks on his face like he's not happy, right? So do you know that we now have facial analog pain scaling in veterinary medicine? Just like people. Are we the happy face, the mad face, the angry face, the crying face? And they've been validated. And so we are starting to get these. And they started out in lab animal with mice and rats and rabbits. We have rhesus macaque now. We have pigs. We have lambs. The horse has now been validated out there. Dogs are a little harder. Cats are a little harder just because of the breed differences in the face. But if we look at our patient and they have increased muscle tone in their face, whatever that translates to in the pug, I have no idea. But if they have increased muscle tone in their face, generally it's because they are uncomfortable in some way. Now, what does he look like to us? That's right. I would have used that word. So we go, nope, we're going to stick the drape back down and we're going to leave you alone for a little while. 45 minutes, we were able to take him out of oxygen, which meant lift the drape up and stop the anesthesia machine from piping oxygen into the cage. And the SpO2 sensor is a reflectance probe, and it was just on his tail with some vet wrap. And so we were able to just monitor with that. So it's that reflectance probe with the light on the emission and the sensor on the little stick. We just put it with vet wrap on his tail. I don't want to undo tape, right, on this cat. And I'm going to have the owner take the vet wrap off. So we go, all right, so 45 minutes later, we could hold the drape up off the front of the cage, and he was saturating in a more acceptable fashion. This says 96. His heart rate's still a little bit high, but look at his face now. Yeah, his posture has changed. His face has changed. He looks different. Sometimes you look at our patient and go, hey, you look different than earlier before. Maybe something's going on. Even if we don't know exactly what it is, something's going on. They're telling us something's going on. If we were in the hospital, we would be dinging the nurse bell button. But since our patients can't do that, we have to kind of look at them and say, hey, you look different. Let's figure out why. So these are just pictures from where I live. And I live in Tucson, Arizona now. And it's a nice place except in July and August. And maybe in June. So, how about this kitty cat? What is the most recognizable thing on this kitty cat's face? She has dilated pupils. Now, she had dilated pupils like this on her physical exam. Because she had not had opioids, which is a rule out, right? So, because that will do it. She has retinal blindness. So, she also has a congenital diaphragmatic hernia. The problem is now that she has lots of resorptive lesions of her teeth. Now, how painful are those? You know, the teeth sort of eat themselves up from the inside out, and once they break to the outside, they're super painful. And the owner said, I really want to get this fixed in her mouth. The surgeon has already said, we don't think she's a good candidate because she was born with this, and there's all kinds of adhesions in her chest from her diaphragmatic hernia. And so reducing the diaphragmatic hernia before she has dental surgery is not really that much of an option, because we're just going to get worse adhesions in the chest. It's going to be tedious. Her risk of hemorrhage or death intra-op from a surgery where you pick the intestines all off the lungs is a big deal. So I said, okay, I'll take her as a patient. Send me her x-rays. And I'm thinking at this time, what? Yeah, that wasn't really what I was thinking, but it translates the clean way to wow. So, and here's the rest of her. So, right now, looking at these x-rays, we need to consider this, and then we need to decide that we go, well, we're going to continue to take her as a patient because the benefits outweigh the risks. I go, how do we minimize the risks of hypoventilation under anesthesia? This patient needs a ventilator. Now, that can be a mechanical ventilator, or that can be your staff person squeezing the bag. I go, how many staff people want to sit there for 2 hours and squeeze the bag? None of them do. So you might have to trade halfway through if you don't have a mechanical ventilator and you have to ventilate a patient for a long period of time. But the principle is exactly the same. Squeeze the bag nicely until you see the chest open. Hold for the briefest period of time and let the bag out nicely. And then we will give 6 or 8 or 10 breaths a minute to this cat, just a nice chest excursion. And you go, but what about manometer? What about manometer? You don't need the manometer. If you can just see the chest excursion and see it open nicely, you don't have to worry about the manometer. You're not going to overinflate the lungs if you open the chest nicely. And then let off, wait between breaths, give a nice breath, hold for just a tiny period of time. That's the natural breath, right? We breathe in, we have, the technical term is inspiratory pause. You just hold it in there for just the briefest amount of time, and then out it comes in a nice passive fashion. And so this cat, we want to do the same thing too. What are the chances we're going to be able to let her breathe spontaneously under anesthesia and not mess up the rest of the lung that she has functional? Like probably 0. And not have a schmancy ventilator, so she went on the ventilator. And go, so what are we thinking this cat's going to need post-op? Oxygen, absolutely right. How are we going to know if she needs it or not? Check her SpO2. You go, man, I know she's going to need oxygen. I just know this cat's going to need oxygen. I'm going to work hard with my little schmancy ventilator so that maybe her lungs are a little more compromised instead of a lot compromised. So we get post-op. Anesthesia time was 68 minutes, which was fabulous because the oral surgeon just worked and worked and worked and was very quick because he understood that the time needed to be short. And he did a great job because he didn't lose his technique when he hurried, which is good. Recovery was very smooth and uneventful. We used NoCETA for local anesthetic blocks, and they were local conduction blocks. You guys all know what NoCETA is? Yeah, so it's a liposomal bupivacaine suspension that will create analgesia for up to 72 hours, which is very nice. In this time of opioid shortage, it's very nice to be able to rely on local anesthetic blocks to provide analgesia. So we go, well, we'll do this because we're going to send her home, and we know that with this almost full mouth extraction that she had, she's going to be painful. Is this a patient that we can keep in the hospital for a long period of time and have him not get all stressed out and uncomfortable? So she's really attached. She's retinally blind. She's really attached to her owner. The most comfortable place would be for her to go home. So we wanted to get her out of the hospital. Is she going to eat now that her painful teeth are out? You betcha. She ate dinner that night. And she ate well. So we go, oh man, she's going to need oxygen therapy post-op. Take her off of the mask when she has good muscle tone, and look what she does. Dang. So I was expecting her to not do particularly well. Heart rate 172, is that what we would expect it to be in a cat? I mean, it's fair, right? It's not 250 and it's not 100. So I go, that's about cat-like. We have really nice plethysmograph waveforms, so this number is likely real. If we don't have good waveforms, the number is likely not real. So we have good waveforms, that 94% is likely real. How long are we going to monitor her? Are we going to say, oh, one reading, we're done? No, we would probably continue to watch her over the next hour or so, which would be smart, just to be sure she doesn't start to trend down and to fall. So we'll have to make a decision that we're going to monitor her for an hour, we're going to monitor her for an hour and a half or 2 hours, and then go from there. But she maintained this SpO2 for a long period of time afterwards, up until she went home. And once she went home, I told the owners, if she starts to breathe heavy, or her respiratory rate goes up, or she starts to look blue, you need to have her be seen right away. She did great. Talked to these people the next day. They're like, this is a brand new cat. She's running around. With lungs like that, she's running around? Really? Okay. So you guys have good sunsets here. We have good sunsets there. So here's Belisario, and she's super sweet. She's a very, very sweet dog. She also is seeing the dentist. She's a 9-year-old German Shepherd mix that's only 16 kgs. Because you go, that doesn't mesh up, right? German Shepherd mix, what's she mixed with? We have no idea. Jack Russell. Jack Russell. So, sorry. Sorry. Presented for right-sided oral nasal fistula. Does this need to be fixed? Yes, it does. So, these are her problems. So, what's the first decision you're going to make? Refer her, right? Yeah, you could call me, and that's okay. Or you would refer her, right? So, who is comfortable with this? I'm not even going to raise my hand. So we go, all right. So, but there's a lot of things to consider here in managing her. But we go, this has gotten to the point where she can't live like that. So we really do need to intervene at this point. And so these are conversations that I have with clients. I say, we have really severe congenital problem going on that's affecting her ability to pump blood and to circulate to her lungs properly, oxygenate her blood. So there's likelihood that she's going to do okay, well supported under anesthesia and monitored, and might have to work really hard, but it's afterwards where patients might decompensate. And so with cardiac patients like this, that first 3 days after anesthesia is, if they're going to decompensate from stress, and we all say stress, you go, what is stress? It's a decompensation because we ran out of reserve in these cardiac patients. It will usually happen in the first 3 days after anesthesia. So the owners need to go home with instructions. If the sleeping respiratory rate goes over 30, if the mucous membranes are not pink, teach them how to look at that. Go teach them how to take a pulse. What's the pulse now? And to keep a log of it. And the cardiologists have parameters for patients and say, we really need to see you back and the biggest thing is the respiratory rate goes over 30 when they're sleeping. So give them that instructions. And so her current medications, she's on these medications. Do we want to have them stop the medications the morning of the procedure? No, we don't. And I talked to the dentist. She needs to eat with these because otherwise they make her nauseated. So I go, can we do her second in the day? Absolutely. So let's give half a breakfast in the morning, give her medications, and then we can plan on sending Serenia home with her, or we can give it to her in the morning when she comes in. That's okay. If we wanted to give her a little bit of metoclopramide to try and empty any food out of her stomach after she gets to the clinic a little more quickly than we might normally have her empty her stomach, that's okay too. And so we go, no, have a little bit of breakfast. We'll just plan for a new time. How long do we really need patients fasted for before anesthesia? So 4 to 6 hours. Now, we used to think it had to be 12, but really it's about 4 to 6 hours. And so once we say have a breakfast at 6 o'clock in the morning, she's ready to go by noontime. Really. And the risk of vomiting and regurgitation is about the same, even compared to patients who are fasted 12 hours or longer. So that's okay. And so she comes in, and this is what we see. Anything here that bothers us? Yeah, her SpO2 bothered me too. So post-op, when she recovers and she's running at 89 or 90%, now are we going to be upset about that? No, because that's where she lives. That's where she lives. So if it's 82%, that would upset me. Go, no, I have to decide what I'm going to do with her then, which is oxygen. So we go, no, 6 out of 6 murmurs. That's plural, because as you move the stethoscope around on her chest, it did sound different everywhere. So I could put the stethoscope on the top of her head and hear murmur up there. Sounded a little different than when listening to the chest, but you could stand in the same room and kind of hear her heart. So we go, pre-anesthetic laboratory testing is all normal. Her PCV is 50%. Now, that's important information because it will indicate to us if she operates in sort of this chronically hypoxemic state, right? Because the body's going to react to that hypoxemia and do what? Make more red cells. So I would expect that if she was chronically hypoxemic in a significant way, that her PCV would be higher than that. And there's no reason to think she was, I'm going to put anemic in quotes. So there's no reason to think that this would be lowered for some disease state that she has. So I go, well, it's not 67 or 70, so maybe she's not as hypoxemic as I would expect her to be with all of those problems. But we still have to watch her oxygen. But I go, that's actually a good start because she has the capacity to oxygenate her blood in a decent fashion. So get Cerenia, same thing, pre-anesthetic IM, IV catheter, the same thing we do for everybody, right? IV catheter, got some crystalloid fluids. Why did I pre-oxygenate her for 12 minutes? That's not a magic number. What am I doing during that time? We put the mask on her, and we're putting on her monitors. Because what we want to do is put as much monitoring on our patient as we can before they go under anesthesia. What happens at anesthesia induction? We create unconsciousness by poisoning the brain with something that if we give a little bit, it doesn't kill you, but if we give a lot, it does. So so we have tremendous change in physiology at that time, and we can see problems developing right from the start if we have the ability to vigilantly watch for them. So how many of us have induced a patient, not had any monitoring on it, and then 5 or 8 minutes later go, what's going on? It comes out of your mouth whether you know that word or not. So because we're behind now, right? We're behind. We didn't see this developing. We see it now as a crisis. So no, if we can see it developing, we can make a change and make some decisions on how to avert a crisis if we have the information to do it. So that's what I was doing in that time. That 12 minutes is not a magic number. It's just how long it took to put her ECG on her, to get her blood pressure, to put the Doppler ultrasound on her, right? Squish, squish, squish. Very nice piece of equipment. Get the pulse oximeter on her somewhere that's not her mouth. It's dentistry, right? How about the pulse ox during dentistry? So yeah, any place that's not on her mouth. So I actually put it between her toes on her toe web. It was very nice. It worked there, lovely. And so again, got everything ready. IV induction, intubation. So inhalant maintenance. The inhalant anesthetic is our enemy when we're looking at blood pressure. Why does the inhalant affect blood pressure so profoundly? Does anybody remember what it does? Vasodilation, exactly. It's a very powerful vasodilator. We would be more afraid of the inhalant if we injected it than we are of dextrometor, if we read the label, right? But we administer it in this really elegant fashion. We pour it into the anesthesia machine, into the vaporizer, and we turn the dial up and down however much we need it, and the machine circulates oxygen to the patient. The patient breathes it in and breathes it out. It has so many profound unwanted side effects, and they're all dose dependent. Is this dog going to manage its circulation particularly well while she's asleep? No, she's not. So we have to decide that the inhalant, although necessary, is our enemy. How do we minimize the inhalant in this patient? Well, yeah, Alfax and CRI, that's what I did for her, but other ways we can do it. Cerenia decreases MAC. Lidocaine decreases MAC. Ketamine decreases MAC. I'm talking about injectable drugs. So we put together a nicely balanced protocol that will decrease the amount of inhalant anesthetic, in a significant fashion so that we can keep that vaporizer dial as low as possible during the procedure. CRI is a great way to do it. Does it have to be alfaxalone? No, that's what I picked. So we're going to provide analgesia with local anesthetic blocks. So do I need an analgesic CRI? Not necessarily. You go, so I just picked the anesthetic, but we could run morphine, lidocaine, ketamine CRI. We could run morphine, lidocaine CRI. We could just run ketamine as a CRI at 0.25 mg per kg per hour. Just a low dose. That will spare MAC. We can give more midazolam or run midazolam as a CRI. There's so many ways to do it. Good local blocks will really reduce the amount of inhalant anesthetic that we need. Put all that stuff into a good protocol, and wow, look how low that vaporizer dial is. And she was comfortable. So we decide right from the start that inhalant is our enemy in this patient. Necessary, but not our friend. So she goes to sleep, and we see this. And it's 1. What are we going to do about it? Nothing is the answer. 1. Would we expect to see some abnormal waveforms on our ECG? Absolutely. How many have to occur before we intervene? Is there a number? Some, exactly. 1, then another one, then a few more, then some more after that. You go, how frequently are they occurring? And are they increasing in frequency? And it's a, what is this? No, I didn't bump her. It could be motion, right? But it wasn't. It was real. So this is a ventricular premature contraction. How do we know? It is big and wide and bizarre. So number 1, it doesn't look like the rest of them, right? So here's the normal interval. This normal interval, this normal interval, here's a normal interval. This came too soon or too late? Too soon. If it's not at the normal interval, there's only 2 choices, right? Too soon or too late? This one came too soon. Now, it's a big complex. This little P wave comes from the atria, right? Because premature complexes can be atrial generated or ventricular generated. So the P wave is really small because the atria are really small. So the atria are incapable, due to their size, of making a waveform this big and bizarre. Even greatly stretched atria like what this dog has, we can see atrial premature contractions have really large anatomy, for lack of a better word, really large presentation or really large deforming of them, but they're never going to be this big. This could only have come from the ventricles. So that's how we know it's a VPC. Did you guys all remember your cardiology so you could go through that with me? Like, not after we've had wine and dinner. So it's a ventricular premature contractions. Now, knowing the cardiac disease in this dog, is that surprising at all? If she had 500 more of these, would that be surprising? Says, well, someone said yes. To me, it would be no, but I'd probably have to fix it. And what would I use to fix it? Lidocaine. And how fast am I going to give the lidocaine? How fast? Right, we draw it up, right? We draw up 4 milligrams per kilogram, and then what are we going to do with it? Are we going to go, shh, 4 mg per kg right in? What can happen if we give local anesthetic too fast? Well, is she going to seizure? She's under anesthesia. What we risk is vasodilation, bradycardia, and cardiovascular collapse. That's what we'll see under anesthesia. So if she was awake, she might seizure, but not asleep. So you go, all right, so I'm going to give this to effect. How do we give things to effect? Give a little bit, wait and see what happens. Give a little bit, wait and see what happens. Give a little bit, wait and see what happens. Go, no, we want to give this in a nice controlled fashion. So we're going to make a choice. We're going to give this over 1 or 2 or 3 minutes, depending on how severe the problem is. So is this a 1, 2, or 3 minute severe problem? This is like there's no problem at all. But if there were 5 or 6 VPCs a minute, they started out at 1, then we're 2, then we're 3 a minute, now we're 5 or 6 a minute. How long do we have to fix that before there's a huge problem? A few minutes, right? A few minutes. It depends on how quickly it's degenerating, right? So relax. It could get worse, but we have some time. So it's all good. So we're going to give it fairly slow and to effect. That's how we want to give almost all of our emergency drugs that we would intervene with. The anticholinergics, lidocaine, epinephrine, all those 3 drugs will fix 95% of the problems under anesthesia that we see. So SpO2 is 100%. That's great, right? What's it going to be when she wakes up? 89 or 91. We could give her a couple of deep breaths under anesthesia to make sure that we limit the atelectasis that occurs. Just that happens under anesthesia naturally, just from the anesthetic process itself. So we could give her, and that's where the sigh comes in. We all kind of learned a sigh is really good. So just give a nice breath, hold it in for a second or 2, and then let it out. Because what we're trying to do is open atelectic alveoli. So we need to hold that breath in a little bit. For a little bit of time. Not a long time, a little bit of time. So again, nice chest excursion. Hold that breath in a little bit longer than the natural breath, and then go ahead and let it back out again. So what the dentist found was this area of discoloration. You see all this? Where it's now discolored? And she biopsied that, and it came back as cancer. So that's the unfortunate thing. Now, is this dog a candidate for everyday anesthesia radiation therapy? No. How easy would it be to remove this part of the jaw on this dog? So the owner elected for just some analgesia for her, some antibiotics. The dentist did take this canine out for the oral nasal fistula, made a flap and go and close the hole there for quality of life. And this dog now has a huge tumor on the side of her face, but she still is eating, she still is drinking, she's still sleeping in the mom's bed. And so this is 7 or 8 months later. How good are we at deciding when our patients are going to end their lifespan? Terrible, exactly. So, and they say, how long do they have to live? I don't know. Well, really, how long do you think they're going to live with this cancer? I don't know. I don't know. So, our clients want answers, right? They want us to have an answer for them. And sometimes the answer really is, I don't know. How long is this dog going to live? I have no idea. It could ulcerate and start to bleed tomorrow, and then it's quality of life, or it could just be a big thing on her face and she's still eating and sleeping with her mom. So total anesthesia time, 84 minutes. Recovery uneventful. She was only oxygen dependent for 25 minutes post-extubation. So we did a fabulous job. So, and this is her post-op. So she's saturating at 94%. What did we do to help her oxygenate her lungs better, oxygenate her blood better? How did we help her lungs? The sigh. I would attribute this to just trying to open up her lungs a little bit more and her not be as atelectic as she might have been. Now, is there magic in that? I have no idea. Well, she was saturating lower beforehand, so why would that be? I think I was just able to help her a little bit. How big is her heart? It's huge, right? Is it squashing her lungs? When the heart squashes the lungs, we create atelectasis, right? And we squash airways. So maybe I was able to open some of those airways that had been kind of chronically squashed in there for a little while. And I was hoping that that was the case. She came back and they checked her SpO2 a couple of days later just to check things, and it was back at 90%. So are you guys wanting to stand up and have a break for a minute? It's kind of dark in here. No, not yet. Okay, perfect. People didn't say, yes! I can usually tell. So Zoe, she's a cute little dog. Now, who's learned one thing they can use in their practice tomorrow? One person. That's a little disappointing. I said, who's learned at least one thing they can use in their practice tomorrow? Okay, good. Okay, that's better. So Zoe is a 7-year-old Chihuahua. She's 2.9 kgs. She has an ulcerated oral mass that they want to excise. This is kind of heavy on dentistry because I do see a lot of patients for dentistry. So, and this dog has a history of hepatic dysfunction. Now, true hepatic dysfunction is not just elevated liver enzymes on the labs. True hepatic dysfunction took 6 days to recover from her spay or her dental procedure or whatever it was. They go, wow, acepromazine doesn't last 6 days. It might last 2, but it's not going to last 6 in a patient with normal hepatic function. So you go, and she also has periodic episodes of stupor. So we go, what diagnostics might we want before we make her sleep under anesthesia again? Bile acids are a really good start. We might want to also get an ultrasound, try to look for shunt, right? And if they can't find one, they usually diagnose them with microvascular hepatic dysplasia, which is okay. So how do we deal with patients like this? We have to start making decisions, right, on what kind of anesthetic protocol we're going to put together for her. Because will she do well with our kind of standard protocol? No. And usually the protocol that's the best protocol is the one that you know and are familiar with. We just lower the doses. We might throw a few more things in there. The idea is to balance the protocol nicely. So use drugs from different categories together in lower doses. We want to use things that are reversible or very short acting. So we throw together this protocol. Oh, do you guys see anything there? I didn't ask that. Can anybody shout out something that they're concerned about? Hypoglycemia. How are we going to manage that? Put some dextrose in her IV fluids. You go, we can do that, right? That's pretty simple. I go, so is there anything else we don't like? And that's an indicator of her hepatic dysfunction. So we don't like the albumin. I go, so what can we do about that? Pardon? Well, head of starch is an option because we'll increase the oncotic pressure. We can plasma transfuse her. So head of starch has a lot of controversy, then no controversy, then a lot of controversy, then no controversy. So we go, but is 2.1 really critical? No, her total solids are 6.4. She's going to be under anesthesia, hopefully a very short period of time. What we're worried about is tissue edema, which is usually pulmonary edema under anesthesia. So if we don't overdose her with crystalloids so that we don't dilute her solids more than that, we'll still have fairly good oncotic pressure in the plasma. We should be okay for that short period of time. So the decision might be to, instead of run 5 mils per kg per hour of fluids, maybe let's run 3. We'll just back off on the fluids a little bit. And her bile acids right there, we can see them. And they're high. So post-induction, wow, she got really deep really fast, right? Did I mean to make her that deep? No. What happened? Would I know this if I didn't have the monitors on right ahead of time, that her systolic fell to 38? Well, how long does it take to get the blood pressure on them after they're asleep? If it's the Doppler, it will take a little bit of time. If it's the oscillometric, we have to wait for it to read, right? We have to put it on, wait for it to read. And then if it doesn't read, what do we say? Stupid machine, that's exactly right. It could never be the patient. It would have to be the machine. So can we palpate pulses on a patient that has a systolic of 38? No, it would be very difficult to do that. So by the time we get to that point, now we're getting further and further behind in this sequence. So if you get your blood pressure on ahead of time and it's reading properly, and all of a sudden they go to sleep and it stops reading, they go, well, maybe that's the patient. Maybe that's the patient. So what do we want to do? Do we want to wait and 5 more minutes until we get more information, or do we want to do something now? So we can decrease the ISO or turn it off, right? Because she looks super deep. You go, okay, what do we want to do about that pressure? Fix it. That's right. So how do we want to fix it? Well, increasing the fluid rate actually is not the answer. And we were taught, all of us were taught to bolus fluids. We all were. There's a lot of information that's coming out in the literature now that basically says fluid boluses are nearly useless for everything but increasing lung water. So we go, all right, we kind of all knew that clinically, right? We kind of all knew that clinically. Bolus fluids, we go, oh, that didn't work. Let's give them more fluids. Oh, that didn't work. So we go, so the recommendation now is to kind of skip that step. And we were all taught that, and I still have a tendency to reach for a fluid bolus. And a bolus is a 3-minute thing. It's not just turning up the drip rate, it's a 3-minute fast thing that we do. How long do the isotonic crystalloids stay in the vasculature for? 70% of them are gone in an hour. So our fluid boluses are very short-lived. And where they like to go when we bolus fluids, the easiest place to translocate to is the lungs, because that's the thinnest barrier. So we go, oh, darn. So turn off the vaporizer. I bolused her a little bit of fluids because I had nothing mixed up ahead of time. I go, she'll probably need a vasopressor or an inotrope. Her pressure is so low, I'm going to need drugs to fix it. Unless she bounces back right away and starts to wake up. But we really want to fix this mass in her mouth, so we'll try to keep her asleep and treat her blood pressure problem at the same time. So I go, okay, so we bolus her fluids and see now it's 48. Do we make a difference? Not really. It's so low, we're going to need some help. I go, so what is the most likely cause of this dog's hypotension? Probably vasodilation, right? That's what I'm thinking. I go, oh, she vasodilated. She's not bradycardic. She's not bradycardic. Is she volume depleted? No, because she didn't bleed. So you go, oh, she probably just vasodilated from the anesthetic drugs. So what we want to do is give her some vascular tone back. So I just picked dopamine. We could pick dopamine, see if that would help. We could pick phenylephrine, ephedrine, norepinephrine. I've run CRIs like this on dilute epinephrine if it's the only thing I have. So you go, all right, so we start that at 3.5 micrograms per kilogram per minute, which I'm going to tell you, if you don't know the dose range, that's low. Well, that's low. Why am I starting it out so low? Well, she's not dead yet. I don't need a high dose. I'm just trying to fix hypotension. Well, so let's start it out low and see if that helps. Because did this dog react typically to her induction drugs? No. She was profoundly influenced by her induction drugs. Maybe she's profoundly influenced by all the other drugs too. So let's start out nice and slow. I go, oh, so now it's 48. Am I making headway? No. We're getting to the point where the kitties are going to start being really angry. So if we're, 2, 3, 4, 5 minutes in, we really need to step up our game. So let's increase it. So I doubled it. Now, that's kind of a big change. Doubling something is kind of a big change in anesthesia. Well, you go, oh, let's double it. Did I make any headway? Right? You go, okay, but now she's getting light. I go, we'd really like to stabilize her to do this procedure today. Now, what's the other choice we could make? She tanked that induction, right? What's the other choice we could make? Instead of let's stabilize her, let's reverse her, wake her up, and say, well, come back and do this another day. And that is a perfectly okay choice. It's inconvenient. That's the only thing it is inconvenient. It's inconvenient for rescheduling. You have to explain to the owner why you woke them up. The owner's going to be frustrated because they have to come back again. They're going to think that their pet is not a candidate for anesthesia or this procedure. We have to reassure them that there's different ways to do things and that we just need a different approach. It's not that their pet can't have anesthesia. It's just that we need a different approach because their pet is different. That, it's just like they need something other than what I picked today. It's my fault. I picked something that wasn't right for your dog. I'd like the opportunity to pick something that is right for your dog. And they're usually okay when you talk to them like that. So we go, well, this was one of those times where we brought a whole team together. I go, so if we have to reschedule, that's another plane flight for me and another overnight hotel stay. And let me see if I can get this dog stabilized. Let me just see if I can do it. So he said, all right, so turn the SIVO back on because she was light. But did her pressure come back up when she was light? Oh, yeah, it went to 62 from what? Yeah. You go, oh, it came back up. Now, is it acceptable? No, it's not. So you go, let's turn the dopamine up a little bit more. Look at this. Woo, we're making some headway. Now she's way too light. So what are we going to do? Now, I can pick at this point to start her on a injectable drug CRI, but how is that going to influence her recovery? Prolong it. It could prolong it, and it could prolong it for quite a while. So we go, well, let's just turn the vaporizer up a little bit and see if I can just manage this. What happened to her pressure when I turned the vaporizer back up? It went down again. I go, no, I don't want to do that. So what did I do with the dopamine? I might have doubled it, but I turned it up a little bit more. So now she's running at 10 micrograms per kilogram per minute. Now that's a moderate dose. You know, it's probably 66% of the dose range. So I still have room to go up if I have to, according to Plum. You know, but according to the dog, it might not be. Look at her systolic. Woo! And her pulse now is 80. Why did her pulse fall as the pressure went up? It's stabilizing, but that's the baroreceptor reflex, right? Do you guys remember the baroreceptor reflex? You go, heart rate and blood pressure hold hands. That's all baroreceptor reflex means, is that heart rate and blood pressure hold hands. And we can't really tell what's going on with one without knowing the other one. So I go, oh, this makes sense. What if we didn't know her blood pressure, but her heart rate was falling and it fell by 50%? What would we think? That her heart wasn't working right. That's usually what we think first, right? Is that she's getting bradycardic, her heart's not working right. But now that we know that the pressure is going up, this makes perfect sense to us because it's a natural physiologic response to increased blood pressure. So do we have to do anything about her heart rate? No. So we go, all right, things are ticking along just fine. Look at this. It's beautiful, right? Okay, nice. There is an equal interval between complexes. There's a P wave with every QRS complex and a QRS complex with every P wave. That's what we're evaluating when we look at these, and they're sweeping past us so quickly we can't keep up with them. You go, oh, this looks really nice. And then we're feeling pretty good about ourselves, right? Everybody's like, yeah, what's coming next? What do you guys think about that? Go, boo, right? Boo. So we go, is there an equal interval between complexes? Go, no. So you go, well, what is this? It's a P wave without a QRS complex, right? Because that's the question, right? Is there a P wave with every QRS complex and a QRS complex with every P wave? So that's a P wave without a QRS complex. So it is indeed heart block, second degree heart block. You go, okay, so here we go. P wave non-conducted to the QRS, P wave non-conducted to the QRS. Oh my gosh, what is this? It is not a VPC. And here's why. Because did this come too soon or too late for the normal interval? Here's the normal interval, here's the normal interval, and normal interval, right? You go, this came too soon. So it's a premature complex if it came too soon. The problem is we have no QRS complexes, right? So in actuality, this ventricle hasn't heard anything from the sinus node, the atria. So what's it thinking? We have to do something or we're going to die. That's exactly what the ventricles are thinking. So this is a ventricular escape beat. You can look at this P wave and say it came too soon compared to this P wave, but these ventricles haven't heard anything. So they're thinking that the heart's not doing anything. They think the sinus node has just taken a picnic and gone to sleep somewhere in a hammock, and it's not working. So you go, well, if it doesn't know that the heart is trying to work, or the ventricles haven't contracted in a while to pump blood out, what is the consequence of not doing something? Death. The consequence of the ventricles not contracting is death. So the ventricles go, I need to contract or we're all going to die. So they take over. So that's the function of the escape beat is, I better do something or we're all going to die. So this is a ventricular escape beat. And then the sinus node tries here, but it's blocked. And it tries here, and we have a conducted QRS complex. And it tries here, and it's blocked. We go, why is this now happening? What did we just do? We increased the dopamine. There you go. So what's the most likely culprit to be causing a problem with cardiac conduction? The dopamine. You go, ugh. So are we going to turn it back down? That'd be my first choice, is turn it back down. What do we think is going to happen to the pressure? Yeah, it might go back down. You go, so the only way we're going to find out is by doing what? By giving it a try. Exactly. So we turn it back down, and this continues. Go, is it a problem? Maybe. What's her blood pressure? That's better than it was. I go, but how would we treat this if we decided to treat it? I go, do we have to treat this? Maybe, right, the answer is always maybe not. Because what if we do decide to treat this? What are we going to treat it with? Atropine or glycopyrrolate, right? And we're going to drop a certain amount, and how fast are we going to give it? Yeah, we're going to, right, 2 effects, so we're going to dribble it in kind of slow. Remember that it takes a while for the drugs to get there when we have poor circulation. So if we're trying to treat a patient with poor circulation, we need to be very patient. So we want to either bolus some fluids behind it or flush behind it with a reasonable amount of fluids for that patient. And I like drawing flush up in syringes because then I can actually measure how much I've given to a patient. Because then I can keep track of it. Because I don't want to overdose the fluids trying to get the emergency drugs in, because then we end up with pulmonary edema and a different problem. So we flush behind it, we give it. When we give an anticholinergic and we already have dopamine running to a patient, what I've seen in the past is a profound tachycardia, more profound than if we just gave the atropine quickly on its own. So what I wanted to do was to stop the dopamine for a second, kind of let it settle in the system for a minute or so, and then go ahead and treat this with some atropine. And it was able to kick the heart rate back up acceptable. What's happened now that the surgeon is working in the mouth? Have I told the surgeon what's going on? I haven't. Because what good is that going to do? Nothing. They're going to freak out, and then they're going to start tying knots in their suture. So if you're a technician, you have to tell your doctor, right? So sometimes I would advise, if your doctor's super excitable, just say, I'm going to give some atropine now. Is that okay? Low key, totally low key, right? And they're going to say, what's going on? You go, there's some P waves without QRS complexes. On a, occasionally, every once in a while. Oh, maybe more often than that. I don't know. So, but it's just like, but they have to know what's going on, right? But if you are all excited, what's that going to do for them? Stresses them out, makes the stress go way up in the OR. So communicate effectively that there are P waves without QRS complexes, second-degree heart block. It's frequent enough to warrant atropine. Can I give some atropine? Just make sure when you're giving it, give it slow. But there's no reason to panic, not yet. Here. So, we decrease the dopamine down, actually, because we fixed the heart rate problem, stop the dopamine. We go, give a little bit of atropine, so we stop the heart block, decrease the dopamine down to 5 mics per kg per minute, and everything settled out very nicely for this patient. And then we woke her up. So when we're making decisions about things that we intervene with, there's good consequences, right? The blood pressure came up, but there could be bad consequences too. Now, the other thing that we could have done if we were going to be in the OR for a long period of time, and this developed, or maybe we were reluctant to give an anticholinergic for some other reason. Maybe this is a dog with heart disease that we're worried about ventricular arrhythmia in or something like that. We can switch the vasopressor or the inotrope. And I've done that before. Dopamine is causing ventricular premature contractions. Well, let's stop that. And let's start dobutamine and see if that one works better. And patients sometimes will tolerate that better. I've switched vasopressin, we don't have available right now, but I've switched from dopamine to vasopressin or vasopressin to dopamine and had a change when something has developed when I started on one that I didn't like, and then have the other one work beautifully in a patient. So we can just switch it also, and that's okay too. So how about Calvin? Is he super cute? There you go. Now, what's the distance between the nose of the French Bulldog and the bifurcation? Less than 0. I love that. I'm going to actually use that. Because that's a perfect description. So what are the chances we will endobronchially intubate this Frenchy Bulldog? Pretty good. Where's the cuff supposed to go? We put the tube in until the cuff disappears behind the vocal cords and then stop pushing the tube in. Now, how much tube is outside the mouth? A lot. Cut it shorter. Does he need a snorkel? Is there any reason we want to treat him with snorkel therapy today? Cut the tube shorter. All of that space from the pilot balloon out is wasted. We have to keep the pilot balloon, right? So, because it's a problem if you cut it off. So, we go, no, so we'll cut it as close to the pilot balloon as we can, trying to get the adapter as close to the nose as possible. Because no one needs snorkel therapy. So the tubes are way, way too long. And you go, oh, we shouldn't be cutting the tubes. We shouldn't be reusing them either. So, no, I can assure you that it costs you more money to clean them than it does to reuse them. We've done the economics between the water, the soap, and the technician time to clean them thoroughly and to care for them. You go, that tube went from being $1.10 to being about $5 a piece when you clean them. You're not saving any money at all. And it's better for your patients because you're introducing foreign protein, soap, debris on a tube that has been cleaned. So veterinary medicine, there are some people in this room who are as old as I am. And I remember when my first tech position, we used to clean the needles and the syringes, autoclave them, and reuse them. And everyone in here who's young is horrified, right? Oh my God, you used to do that? Well, they thought it saved money. But what kind of patient care is that? Would we do that now? Never. The endotracheal tubes are coming under that category. We really should use a new one for each patient. So I urge you to consider not just if you go, oh my gosh, my standard is so low, I'm going to reuse my endotracheal tubes. I go, if you can't cope with that, say it's costing me money to reuse them. Let's increase our standard of care and let's increase our revenue. And if you have to, they cost $1.10. How much is your anesthesia fee right now? Tack on $2. I'm sure your clients would pay it if you said, now do you want a new endotracheal tube for your pet? Or do you want us to use the old one from the pet before that? I tell you, they would tell you to use a new one. So we're going to cut Calvin's tube shorter. We're going to use a new one. We're going to cut Calvin's tube shorter. What are the chances we're still going to endobronchially intubate him? Pretty good. So we go, here's a French bulldog, dental cleaning, pretty unremarkable in every way. You go, oh my gosh, a normal patient. What are we going to do with this? I don't know what to do with him because he doesn't have 7 problems. I look at the possible anesthetic drugs and go, not that one, not that one, not that one. And by the time I whittle him down, I go, well, here's the protocol. It's the 2 drugs that are left. So this guy, I can use anything. But when we get him hooked up to the capnography, this is what's happening. Go, I was worried I would endobronchially intubate him. If we endobronchially intubate him, will we have tremendous rebreathing of CO2 like this? Now, he's breathing out 52 millimeters of mercury of CO2, but he's breathing in 24. Or is this problem coming from someplace else? Where does rebreathing of CO2 come from? Does it come from down in the lungs or does it come from outside the body? From outside the body. We cut the tube so that it was almost to his nose. So is he rebreathing out of the snorkel? No, because there isn't a snorkel. So you go, is there enough adapters on there for measuring stuff? My end-tidal CO2 adapter and perhaps in the Y piece to create this much rebreathing? You go, probably not this much. So now we have to start looking at equipment because the end-tidal CO2 tells us about our equipment too. Well, look up at the equipment and this is the flutter valve. It's stuck up there. Yeah, the machine had been opened the night before because it had a bunch of condensate in it from a big dog and it was allowed to dry out. And then when it was put back together, the person was distracted. Human factors, right? Medical mistakes, they were distracted and in a hurry. And what happened to this? It got wedged up in there. So this is the expiratory valve on the anesthesia machine. So now the gas is just going out and in, path of least resistance in this dog. So the dead space actually is that whole limb of the breathing circuit, not just the adapters that are here now in the snorkel on him. Go, oh darn, what do we need to do? Fix it. Do we leave the oxygen and inhalant on while we open it up and fix it? Well, we could, but are your friends in the clinic already irritable and have headaches? Yeah, so the idea is waste gas, the primary problem that we see with waste gas that manifests on the outside of us is that we're irritable and we get headaches. And so chronic fatigue has been associated with exposure to waste inhalant gas on a chronic basis. The rest of the health problems are infrequent enough where we don't have good statistics on them. But if it gives us a headache, if it makes us fatigued, if it makes us irritable, it's changing our physiology somehow. And it's better to stay away from it. So turn the oxygen. You don't necessarily have to turn the vaporizer off, but turn the oxygen off. Fix it and then put all this back on. So, and now we end up with this. We go, oh, we fixed this, not a rebreathing of CO2, right? And the end tidal CO2 is 43 now. But when we look at Kelvin breathe, we go exhalation, inhalation. And here's that little inspiratory pause. An exhalation, an inhalation. What in the world is this little dip? We don't see it on the outside of him. It's something happening on the inside. What's on the inside of him? His chest opens and recoils, and opens and recoils. We don't see it open, recoil, then recoil. We see it open and recoil. So is this a problem with his ventilatory pattern? Or the breathing pattern of his chest? Of the actual chest movement? No, exactly. Because the chest movement is out and in, very smooth. Out and in, very smooth. Reservoir bags going, decreasing volume, increasing volume. Decreasing volume, increasing volume. What we see in this waveform is something that's happening where does the CO2 come from? Everybody's like, oh my God, another question. Where does the CO2 come from? The lungs, right? The lungs, it comes from the lungs. So the CO2 comes out of the lungs, then stops coming out of the lungs, then comes out of the lungs a little bit more, and then he breathes in. So this is, I love this word, pathognomonic. This capnogram waveform is pathognomonic for endobronchial intubation right at the bifurcation. And it's differential lung emptying. And what happens is that the lungs will empty mostly out of the main port of the endotracheal tube, and then we need a little more recoil on the chest to push the rest of the gas through the Murphy eye. You guys know what that little Murphy eye is, right? That little tiny hole in the endotracheal tube. So we need to back this tube out maybe 3 or 4 millimeters to stop this differential lung emptying from happening. He could have a partially collapsed main stem bronchus. That's the other thing, other time we might see this. We might not be endobronchially intubated. He may have a partially collapsed or collapsing main stem bronchus. We could see the same pattern from that. The first step is to pull the tube back a little bit and see if it's only a problem with the tube being right at the bifurcation. So it's sort of a minimal endobronchial intubation. And then we went ahead and untied, deflated the cuff, pulled the tube a little bit, reinflated the cuff, and it was fixed. Now our capnogram waveforms look properly like elephants following elephants. Can you guys see that in your imaginoscope? Elephants following elephants. On the circle system, that's the correct waveform for the end tidal CO2. So there were 2 problems in this dog. How are we doing on time? You're my timer lady. Okay. All right. I don't want to keep people here too late. Now, we are all clinicians, right? And really good technicians. So Tommy is what? He's a cat. And Tommy is old or young? Old. What does Tommy have? Kidney failure, hyperthyroidism. Come on, keep them coming. Hypertrophic cardiomyopathy. He doesn't have diabetes quite yet. And his IBD is not lymphoma yet, right? So we're working on those things. So Tommy, how old do you guys think Tommy is? Oh, come on. So if you take a look at this picture, this eye is bigger than that eye, right? He does look good for 21. And his owners think that he has a decent quality of life, except that he has glaucoma in that eye that's failed medical treatment. So, yeah, he's a walking medical bill. You can look at that and say, yes, this cat is a walking medical bill. So, look at all of these things and tell me why we would anesthetize him today. It's this one. He's painful in his eye, and he's kind of stopped eating. And he's holding his head to the side because his eye hurts, and he's failed medical treatment. And the ocular surgeon said the only way we can help him is to take his eye out. And so the owner said, okay, let's try. We love Tommy. Let's improve his quality of life. Let's have his eye out. And the next thing the ocular surgeon said was, it's going to cost you some more money because I have to do what? Yeah, I have to call the anesthesiologist. And the owner said, cool, bring her in. So we did it. So, anything here surprising to us? Anything unexpected? With his history, is there anything unexpected? Nope. I would say that all that stuff we would expect. Is there anything here that would keep us from moving forward today? Is there anything we're going to be able to fix and make better for next week? No, probably not. So, okay, good, let's do it. So, here's his echocardiogram. You go, left atrial enlargement, hypertrophic cardiomyopathy. Now, his ejection fraction is 85%. Well, normal's like 50. I mean, I know there's a range, but you go, so we need some reserve, right? How much reserve does his heart have? It's at least not collapsing, right? If we need it to pump out a little bit more blood on each beat, we have 15% we can work with. Or 14% we can work with. Do we want to work with it? No, but it's there, right? His fractional shortening is 50%. Now that's sort of a misleading number in these hypertrophic cardiomyopathy cats, because we go normal heart will contract about 33%, 40%, something like that, right? Because we can't contract our muscle to zero, right? It can only contract a certain point because it still has mass to it. So his heart is working kind of hard in dogs that have normal hearts with ejection fractions of 85%. Those fractional shortening numbers would be up at like 60% or 62, 63%. So this is short because the chambers are smaller in hypertrophic cardiomyopathy cats. This muscle is working about as hard as it can to eject 85% of the blood from the heart at that time. So we don't have a lot of reserve there. So one of the main things we need to do is make sure that his heart rate stays about what it is in his normal awake compensated state. Because if it slows down, what's going to happen to cardiac output? It's going to go down. If it speeds up too much, what's going to happen to his cardiac muscle? It's diseased, right? How much oxygen does it need? If it speeds up, how much extra blood is it going to be able to pump out in cardiac output? We're going to maybe lose, especially if it's obstructive in some way, we're going to lose stroke volume, and we're going to end up again with angry myocardium. What are the chances this cat's going to have arrhythmia under anesthesia? Pretty good, right? So if he develops something under anesthesia, go, oh yeah, we were prepared for that. So how do we prepare? At least print out or calculate out the emergency drugs you might need to use. Let's know what volume of lidocaine would be appropriate. Let's know what volume of any other emergency drug we think we might need would be appropriate. So we go pre-thrombotic environment. He's on Plavix. Do we want to stop any of these ahead of time? Do we know how far in advance we stop Plavix to not have bleeding problems? No idea. Nobody knows. Nobody knows. So, right. But in cats, they go, got no clue. Who's going to do a Plavix study on cats and do bleeding times? Ain't no money in that. So you go, well, okay. So if there's a pre-thrombotic environment in there, do we want him to make a clot? No. We're going to do an enucleation. Now, does the surgeon have some capacity to control hemorrhage during the enucleation? Yeah. So they talked to the surgeon, can you have very good hemostatic technique, please? He said, yeah, I have some cautery and some gel foam. We're good. Okay, but can you please watch it? Because, you know, what I don't want to do is to pull him off too soon, have him develop a clot in there, and then when will he throw the clot? When he goes home. Exactly, right when he goes home. And then it goes, you know, all of this, and there's a clot. So they go, we're going to have him stay on all these things, except maybe the Plavix, and take him off a day or two in advance, but that's surgeon preference for me. I don't have a recommendation there because there's no guidelines to go from in cats. So they go, surgeon can decide because they deal with the blood loss. But I would really like for him to stay on it as long as we can keep him on it because of the potential for him to make a thrombus in his atria. So they go, all right, does this cat need breakfast that morning? A 21-year-old cat, how well are they going to handle being taken off food for 12 hours or 6 hours? He's already not eating that well in the first place. I go, how about your grandma? How is she when she's missing a meal? You guys who have grandmas know. Yeah. You go, we don't handle it as well when we're older. You know, when we were at university, we could drink beer all night and not eat for like the whole next day because we were too sick from drinking beer the whole night before, and make it out again that night because we felt so good. We might have gone to class, or maybe not. But we could do things like that, and we'd be able to go home and fake it to our parents because we had lots of reserve and some energy, right? We go, these guys can't do that. And as we age, we can't miss meals. What is that, hangry? We get hangry. Our physiology is changing. Our glucose is changing rapidly, and it's changing the way that our bodies work. Do we want anything to make Tommy unstable? Nope. So go to the ocular surgeon. Thank goodness you're going to play golf that morning because we're going to give Tommy breakfast, and I'd really like for him to have his procedure around noontime. And then he can have his dinner, too, because he might feel better when he wakes up. So we'll just plan it in the middle of the day and let him have a breakfast. So we get everything ready. We hook him up to the ECG, and we see this. Now, cats will never, ever give us a good ECG, right? It's always microscopic. So, but again, we're going to ask those same questions. Is the interval between the complexes equally spaced? I go, no, it's not, because this is further apart, closer together, further apart, a little bit closer together, further apart, closer together. I go, is there a P wave with every QRS complex? Well, if I can find them, there's a P wave, right? There's a P wave. Oh, here's a P wave right there. And here's another one. I go, okay, is there a QRS complex with every P wave? I think so. Well, if there is a QRS complex that's a normal-looking QRS complex, let's look at this one. They go, this is a normal-looking QRS complex. Here's a nice P wave. Here is the collection of electrical signal at the AV node. Then it goes into the ventricles, QRS complex, and the T wave follows on. They go, and here's, I can't find the P wave there, but I know what normal is here, and this QRS complex is normal. Do all these QRS complexes look normally conducted? They all look the same. So that means the electricity got to the ventricles through the AV node. So it came from a normal pathway. So the problem is probably north of the AV node. Does that make sense? What's north of the AV node? The atria and the sinus node. To get a complex, does it have to come from the sinus node? The answer is no, it doesn't, because it can be an atrial generated complex or a ventricular generated complex. Does that make sense? Does that make sense? We don't have to have heartbeats start with a sinus node. They can start with the atria, they can start with the ventricles, or the sinus node. So now we have to say, do we think these complexes came too soon or too late? And what's the normal interval? Is the long spacing the normal interval, or is the short spacing the normal interval? What do you think? Do you think they came too soon or too late? I think they came too soon. Because here's a normal P wave in a QRS complex, and then I have this is a turtle. Someone stuck a turtle in there. But this is a normal QRS complex. So what likely is this lump made up of? the T wave and the P wave together, right? So we go, can we find a normal T wave on here? Well, that looks like it might be a normal one. How big is that? Kind of small. How big is the P wave that follows it? Kind of small. How big is this? Kind of big. When you add kind of small together, what does that equal? Like medium. So, but if you have a P wave that's bigger than the other P waves, and you add it to the T wave, we would be able to count these boxes, right? So how many boxes are under the normal P wave? Like 1. How many are under the normal T wave? Like 1. How many are under this? 3 or 4, right? So this makes us expert cardiologists, right? We've counted boxes. So my point is that there was probably contribution there that was not, or that was beyond what a normal P wave or what a normal T wave would be. So if a complex comes too soon, and it is a larger complex than the normal ones, we call it a premature complex, right? Atrial premature complexes are made up of larger P waves than normal that come too soon. What's the likelihood these are atrial premature contractions, knowing that his left atrium is really big and diseased? We go, so we know he's predisposed to them. We know he's predisposed to them. We know that we have complexes coming too soon. We can't see the P waves, but we've added up the boxes and said something in there is bigger than normal. It's most likely the P wave, not the T wave. So we have put together evidence to say we can't see the atrial premature contractions, right? So we have to put together evidence that supports that diagnosis. Does that make sense? We have to put together the evidence that supports that diagnosis. So it's a little more difficult than looking at the labs and saying, yep, the T4 is too high. Right? It's a little more difficult than that because we have to think and we have to make some assumptions, which sometimes are bad. But the question is, if we go, all right, it makes sense that he would have atrial premature contractions based on his history and the condition of his heart. We have abnormally spaced complexes on the electrocardiogram. We can't clearly identify atrial premature contractions as large, bizarre P waves, but we have evidence to support the fact that there is something that is probably larger than normal in that coalesced complex, that coalesced T wave, P wave complex. So we go, all right, they're likely APCs. Do we have to treat them? No, not necessarily. Absolutely. That's always the answer. Do we have to treat this? Nope. Should we treat it? I don't know. You go, is this something that's been seen in Tommy previously? Could this have developed today because of stress or because of aggravation with us touching him? Or could his cardiac condition be worsening today? We go, any of those things, right? If we choose to treat this, what would we treat this with? The atria is myocardium, right? What drug do we use to stabilize the myocardium? Lidocaine. Exactly. So you go, let's pull up some lidocaine. Let's see if it does anything. Now, atrial premature contractions might be more difficult to treat with lidocaine than ventricular premature contractions. So what would be the next drug in line if he didn't respond to this and we absolutely needed to stabilize it? We go procainamide. So how many of us have procainamide sitting on our shelf in our practice? We go, what if he doesn't respond to lidocaine? Is the whole day lost? No, because what are we going to assess? His blood pressure, right? We're going to assess his blood pressure. Get some assessment of circulation. If his circulation is okay, let's move forward. Okay, what are the chances he's going to fibrillate from atrial premature contractions? Not as high as if they were ventricular premature complexes or ventricular tachycardia. We incited some type of problem like that. The ventricles are more likely to cause a catastrophic problem than the atria are. So you go, all right, we'll give him some lidocaine. By Gemini, that just means they come every other one. Did you guys see they came every other one? Okay, good. So induction, a little bit of alfaxolone, sevoflurane. Look how low that sevoflurane was. Where is sevoflurane usually set on the vaporizer? About 3%. So 75%, 0.75% is much less than 3%. Why did he not need very much inhalant? Because he's old. That's exactly right. As we age, we need less and less to accomplish the same level of anesthesia as we did when we were younger. Unless you're a redhead, and then you still need more. So anesthesia time, 38 minutes. He did really, really well. But the whole point of that is, if you take a supragenarian patient like this, right, supragenarian, exceeded life expectancy, if you take that supragenarian patient and you turn the vaporizer dial all the way up to 3, what's going to happen? Very likely we will overdose him. And it's an inadvertent overdose, because we didn't say, I'm going to turn you up to 3 and kill you. It's just that we are so used to turning that vaporizer dial to 3 or turning it to 2. I go, that's just automatic, right? So in these supragenarian patients, we have to stop and think and go, they need such a small amount. Let's get out of our comfort zone and turn it up just a little bit. And let's see where they are. What's the worst thing that happens if he gets light? We have to turn him up or give him a little more induction drug. What's the worst thing that happens if we overdose him? Dies. Where do we want to be? Light, exactly. So we need to be careful not only with our inhalant drug doses, but also our injectable drug doses also. So we want to scale them back. We want to, and the human literature says a 50% dose reduction by life expectancy. Start at half life expectancy to reduce doses about 10% every decade until we reach life expectancy where we should be scaling by about 50%. Now, how old is Tommy? What's life expectancy in the cat? Yeah, so he's beyond life expectancy. So you go, well, maybe we need to scale more than 50% on our drug doses. And then I like to reverse as much as I can in these patients also, because it really helps them, especially like midazolam, reverse it with flumazenil. They regain their muscle strength more quickly. Their coordination comes back more quickly. Their problem-solving mentation usually follows that. One of the risks in our supragenarian patients is long-term memory deficits. And long-term would mean temporary but last a while, or permanent, which lasts the rest of their life. How many of us have seen a patient that had a procedure that just was never the same afterwards and faded and died after 6 weeks? If you practice long enough, you will see that. Because what we did was decompensate them, and they just didn't bounce back from it. So part of that preventing decompensation is lowering the drug doses, and especially exposure to inhalant, which means shorter procedures, lower inhalant concentration. All right, perfect. Now did we achieve the goals? Everybody learned 3 things they can use tomorrow. Most everybody stayed awake. So what I can say is thank you so much for coming tonight and listening to me talk about something that I'm truly passionate about. And I appreciate the opportunity to be here this evening to give this talk to you.